and Claire.
All right, but I think the waiting room is slowing down if we want to get started.
Great. Go ahead to the next slide. As always, we start every Connecting for Better Health Coalition meeting with our vision and our policy priorities. We also encourage folks to introduce yourself in chat, especially if today is your first ever Connecting for Better Health meeting. Thank you so much for joining us. We look forward to getting to know you better and learning more about your work. The vision of this coalition is that every Californian and their care teams have the information and insights they need to make care seamless, high quality, and affordable. Each year, we set policy priorities as a group. The 4 on the screen here were voted on by all of you for 2025. Our priorities are to establish DXF, or Data Exchange Framework, Governance and Accountability, identify dedicated and sustained funding streams, strengthen social services data sharing, advance high quality and actionable data sharing. We can go ahead to the next slide. Thanks all for using the chat throughout all of today's meeting. We have a really fantastic agenda today. It's going to be packed. We're going to move quickly. We're going to spend some time on the recently announced CMS interoperability framework. We have a number of guest speakers to share their perspectives on the recent announcement from the White House at the end of July. We also have a fantastic guest presentation from LA Care and Lanes around their work on FHIR recently. And we'll wrap up with some very rapid fire policy developments at both the state and the federal level. The Rural Health Transformation Fund that was included in the reconciliation bill signed in July, as well as some additional updates. And end with our coalition business, including our annual dinner, Save the Date, which hopefully everyone received over email. Okay, let's move ahead. You can go ahead to the next slide. I'm really excited that we're joined by Claire Ernst today. Claire is a partner of ours from the Hooper Lundy and Bookman team in Washington, DC. And Claire is going to join us for a few minutes on a brief overview around the interoperability framework and the Make Health Tech Great Again event that was hosted on July 30th, before we open it up to our panel of speakers. Claire, I will hand it over to you. Thanks for being here.
Thank you. And thanks. I'm sorry I'm a minute late. I was having the irony of interoperability. I was having just problems logging on from my from my work emails, but I've figured it out. Okay. Again, thanks for having me. I'm Claire Ernst. I'm with the Hooper Lundy Bookman team. I work with Andrea, who, if she's not on, I was just on another call with her discussing this actually, and so she'll be on shortly. So I'm just going to give a really quick overview of what happened and a little bit the other week when this was announced on July 30th, and also a little bit about sort of the environment that's going on in DC right now. I am physically right outside of DC. I'm in Maryland, but I work in DC, and so I get the luxury of having all different experiences all over the DMV. But I can also talk a little bit about sort of what is happening with ASTP, ONC, and CMS. So the other week, the White House with CMS and HHS announced this initiative, Make Health Tech Great Again, and that's where they unveiled the CMS interoperability framework. Prior to this, I think some of the private companies who were involved in this they obviously had more of a heads up, but there was a lot of talk around the industry, a lot of trade groups. We were all very, we had heard that there was going to be an interoperability event at the White House, and everyone was sort of texting each other several weeks prior, trying to figure out what that exactly was. And then we found out, and this is what it was. So basically the framework, as indicated on this slide, is it divides the categories, it divides things, it breaks things up into different buckets, right? Patient access empowerment, provider access and delegation, data availability and standards compliance, network connectivity and transparency, and identity, security and trust. Do you want to go to the next slide? I can't remember if you said, okay, thank you. This is where I'm going with this. So, okay, so there are the quote early adopters that are providers, payers, EHRs, patient-facing apps. There are I'm just pulling up some of the other ones so I can see. So in terms of the data networks, there are, we have Epic, we have Datavant, we have eClinicalWorks. There's a bunch of them that we've all heard of before. Most of them were at this event. We also have a bunch of providers, including healthcare systems like the Cleveland Clinic and CVS Health, United Health Group, Intermountain Health, that were all there as well. Some of the payers, which include Medicare themselves, United Health again, Elevance, Humana, and Aetna. And then there are these patient-facing apps, so like Noom, WellDoc, Virtua Health, all of those. So those are the folks that were at this event. I think, there still seems to be a bunch of questions that we, like personally, I have, and others as well. I think some of those being, how does this align with TEFCA? How does this align with QHINs? Truly, like, what does this mean? There's also some statements and comments made from OCR about HIPAA and how that will play into this. And so I think those are things that, at least from our end at HLB and also my friends and colleagues across the industry, we're still trying to make some more, seeking some more clarity. I think another thing that's important to note is, somewhat relatedly, a week or so prior to this, there was another event at the White House with CMS that dealt with prior authorization reform. This was another essentially like private sector effort where 60 or so plans under the leadership of the Blue Cross Blue Shield Association and AHIP had come together and had said that they were going to make these, handful of reforms. Some of those reforms were are mandated anyways, in part, in regulations, like through the interoperability and prior auth final rule from several years ago that has yet to be fully implemented. But other ones are, just common complaints from providers and health systems about, much needed prior auth reform. A lot of those pledges, though, are, they're pretty vague, and they have some like far out deadlines, and the White House, sort of like the CMS and HHS were very like okay, like the plans are going to do something, they're saying they're going to do something, they're going to pledge. And so when I saw that this interoperability, like this ecosystem, came out several weeks later, it kind of resonated with that whole effort from the administration to really get the private sector involved, which is not unusual. Which is not so different from the first Trump administration. And but there's like different ways to interpret that. One way to interpret it, right, is that, okay, great, like we're getting private sector involved. They know what they're doing. They're leaner. They're not as weighed down by the bureaucracies of federal government. So maybe we can make some real progress in these ways. And I think that is more, that message is demonstrated more in the inside the Beltway and like trade publication, reporting out of this event, and in the subsequent framework. But then, another way to think about it too is when private sector is, when the federal government is essentially deferring to pledges by the private sector to do things, some might think, and we saw this from the outside the Beltway, like non-trade publications like AP, MSNBC, we see those publications sort of curating a different story than the inside the Beltway trade publications, where the emphasis is more on, well, we should, as consumers and patients, we should be really cautious. We should be, we don't know what they're going to do with this data. And so in some ways, like it is really interesting, just the sort of dichotomy of how it's been reported on. I think definitely in like my sort of health IT circles, where, you know, the different trade associations that work in this space, we're all focusing on more so the interoperability side of things and what that really means, with also the caveat of like, we're not sure exactly what this all really means in terms of like TEFCA involvement and where they're planning on going from this.
Claire, would you be able to walk through the specifics so that we can then have the reaction from our team
Yeah.
that we pulled on to? Okay, awesome.
Sure. I'm going to caveat this with like, there are specifics, but they're not like really that
Right, I should say
specific.
specifics.
Okay, all right,
Gosh,
okay, sure. But like I would appreciate, yeah, like hearing from you all on like how not specific they are, or if it's just me having 1,000 questions about how some of this would work, or if I'm overthinking it. So I can go through these slides. I have some of my other notes pulled up. Okay, so yeah, I'm just making sure okay, yeah, that's helpful. Okay, so for the patient access, they're talking about, and none of this, by the way, like a lot of this, as I'm sure you all are well aware, like a lot of this is like not new. We've been talking about patient apps at a federal level for a really long time. You know, this is like we've seen in other ways within this administration, certain things like with Make America Healthy Again that have been like, you know, ideas that have been around for a while, and now they're sort of resurrecting themselves as these new ideas. And I think that in some ways this is not that different. So from the framework criteria, right? So they talk about patient access and empowerment. So basically patients being able to access their electronic medical information using the applications that they want. Patients being able to access their claims, explanation of benefits, prior auth, and clinical data from current and past payers, which I think is really interesting. Would be curious about your thoughts on how doable and any sort of challenges security-wise that presents. They talk about no additional login or portal info required, audit log transparency, patient consent preferences. So for the second sort of bucket, provider access and delegation, right? So for full treatment access, if a provider uses an identity verified credential, it's validated as the active provider in the CMS National Provider Directory. This is another thing with the provider directory, also not a new concept, the provider directory.
Right.
I mean,
Claire, I'm just looking at our time.
okay,
I'm going to just open it up to our panel that we have, a few
Sure.
who are in the room, that will be able to, I think, address these, and everybody has hopefully, or maybe we can go to the next slide, right? And maybe we can put the link to the slides in the chat to be able to have that as reference. And if we could just move to our panel. Thank you, Claire.
Yep.
Awesome. So I know, Lisa, you were actually in the room. We'd love to hear from you. And then also Michael, Devin, Marilee, we've been following all of your commentary, and would love to be able to hear how you are seeing this announcement. And I think there's incredible excitement, and where and how that's going to be able to be something that we can take into our work day to day. So Lisa, would you be able to kick us off?
Sure. And there's a perfectly reasonable question in the chat from Stuart about CMS having the opportunity to double down on TEFCA and QHINs, but they did not do that. Is this the death of TEFCA? I agree with Michael here, unsurprisingly, no. I think from a few months ago when CMS had this health technology ecosystem RFI, They asked for a lot of feedback, and they also signaled at that point that they would not be, dubbing any particular TEFCA QHIN or method for exchanging data as the winner, but rather they've been saying since then, before this event months ago, that CMS will participate in trusted exchange. And then they made clear, a little bit clearer, I would say, what that means, which is that they're going to be working with different networks who are going to be trying to become CMS aligned networks. TEFCA QHIN can be a CMS aligned network, also a regional or statewide HIE or a private HIE or health technology company. These folks can also all become CMS aligned networks. And yes, there are more questions than answers. We're not done yet, but what they did say pretty clearly is that, sure, QHINs probably will meet those requirements. They didn't say TEFCA doesn't exist anymore. They just said CMS is going to be exchanging data this way, and we're going to encourage others to do the same. So what's different to me is CMS making a commitment that they will also be part of this work, that they will be sharing and exchanging data for legal purposes, et cetera. So I think that's the difference. People are getting really caught up on it. Like, is this mean TEFCA is dead? And I'm like, well, no, it just means that they're saying what's different is that they're going to participate in exchange, and they are having a broader view of what CMS aligned networks are than what TEFCA QHINs are. Is it helpful? Is it complicated? Yeah, all of the above, right? More questions than answers, but that's the difference here from my perspective.
I love that. And Michael, I know you want to jump in. I've seen you on the chat. Go for it.
Yeah, love to jump in. I mean, aside from not being one of the cool kids, I mean, I wasn't actually in the room.
Many of us were not cool.
Giant FOMO from California here. But I think that, to some of Lisa's points, I think that what this does is it moves the ball forward in that, as opposed to ASTP and ONC carrying the TEFCA ball, we've actually moved it up a notch at a CMS and even HHS level, where they're actually signing on to this alignment across, again, multiple frameworks and networks and possible opportunities to connect. The other piece in the reframing is really more of a patient focus, or at least the way I've read this is that it's more patient centric than what we've had traditionally as a more provider and technology centric, standard centric way to go about this. So looking at open networks and open frameworks and the ability to leverage standards, FHIR APIs, USCDI, to do that exchange, those are things that are in place. The technology hasn't really been the rub here. It's really been trust. It's been the directory, which I think is a big step forward. If directory is done correctly, it'll help facilitate some of this. And it allows multiple partners, depending on where you're coming from. Kristen Valdez wrote a really great article about what this isn't on LinkedIn. If you don't follow Kristen from BeWell, the CEO of BeWell, she did a really good analysis of kind of what this isn't, or what are the rumors. So if you haven't looked at that, I'd tell you take a look at that. And I was co-authored, and I apologize to the co-author. I can't remember her name off the top of my head. Anyway, I think it was Jill DeGraff. Okay, thank you. Anyway, so from that standpoint, as a healthcare provider, what we're looking at is leveraging existing standards and having this be open. And I think the idea that if all the things that I read that allow us to not be responsible and held liable for all the exchange, and we can offload those responsibilities to the patient, we would love that, but that's not what's going to happen. But I think that this at least opens the door to help facilitate some of those things that I think a lot of folks are interested in: empowering patients, letting them be the center of their exchange, and opening this up to more participants. As you saw in the 60 organizations that signed, not all of them are traditional, EHR technology vendors. A lot of different segments of the technology ecosystem are jumping in to participate. Maybe they see dollar signs attached. Maybe they're actually in it for patient good. I can't tell you what their incentives are, but I think from a provider standpoint, the more the merrier adopting these standards and participating. So.
Well, and that's fantastic. And Devin, I know you've been working, I remember the Civitas presentation around the identity proofing that you were doing. I'm hoping that there's some connection there. You want to jump in?
Well, here's what I see about this effort and why we signed 2 of the pledges as a patient facing application, maybe not one of the ones that folks have heard about before, although certainly if you know me, you would know we've been working on this for quite some time. I feel like what CMS is doing here, I'm in complete agreement with Lisa and Michael that this is not like, oh, we're not dealing with TEFCA anymore and it's going to die. I think CMS wants to go fast and is basically taking a group of entities who have signed various pledges and said, are you going to lean in on this? Because we're going to participate more actively than we have before as an agency with our data, with the muscle that we've got. And we're going to do so on an escalated set of timeframes. We are a bit weary of waiting for these use cases to take off more robustly. This consensus building process orientation of the networks that we've got takes a long time, understandably so. You've got lots of stakeholders at the table. It takes a very long time to get things done. I feel like CMS and this effort being led by Amy Gleason, she is a person who's just accustomed to trying to move a lot more quickly and break down maybe some bureaucratic barriers that sometimes can get in the way of making faster progress. So missed the event in DC. I was actually in California too, Michael, my husband's birthday. We were out celebrating. I'm like, I pretty much won't be married anymore if I tell him that I have to go to a White House event and we're skipping his birthday dinner. But we signed these pledges, and my view is that, yeah, there's still a lot. There are some things that need to get resolved, including what particular identity sort of policies are they going to follow. And frankly, I think they're going to borrow heavily from some of the stuff that's already been put in place in our existing networks, because you don't want to, why would you start from scratch if your aim is to move quickly? But yeah, they've got some stuff that they need to shore up, and they've talked about it. They're going to create working groups of the folks who have signed the pledges, and frankly, the pledges are still open for other people to join. It wasn't, intended to be foreclosed to other participants, is my understanding. And we kicked the tires on it, and it didn't look like we were going to be jeopardizing the data of our users, putting it into some central database that the federal government would have access to. Same privacy policies apply, same state laws apply if you are required to abide by them. Will they pick up some other pieces of, like, say, TEFCA around contractual commitments to HIPAA for patient apps that aren't currently covered by it? Maybe, maybe not, we'll see. But we really saw an opportunity, to potentially cut through some of the sluggishness, I'll say, that has kept individual access as a use case in some of these national networks from really taking off, to try to get that done a little bit more quickly. For the patient access pieces of the sort of two pledges, one involving taking that data and making it more actionable to patients using AI, which was something that we had already begun to do. And then the second one, which is called Kill the Clipboard, involves the ability for people to quickly get their data at a participating institution into their chosen app, and then share that data back with consent, so that maybe we can stop filling out as frequently as we do today those forms that we have to do at every single new provider we go to that ask a lot of some of the same questions, and having to fill them out by hand over and over again. So
how I interpret that too, just a page out of Connecting for Better Health, is accelerate, go fast, and really lift up what's happening.
Yeah.
And being able to be still have the guidelines of principles, which we're seeing that also very much guide our work. And Marilee, I know you've also been really thinking about this TEFCA versus everything else world. If you wouldn't mind, be able to share your thoughts. And I just want to make sure, like, everybody knows we were really kind of cram this in. We know it's a really hot topic, and we can continue to keep this conversation going. I really would love for folks to be able to put in chat questions. And look who you have. You have these amazing experts here. So Marilee, please, I want to be able to make sure that we hear your perspective as well.
Yeah, and I'll try not to repeat what others have already stated that I agree with. I think great network agnostic. I think it's absolutely a win for TEFCA. And interestingly, we're very closely tied into the QHIN. So even though we weren't at the meeting, we spoke to a QHIN who was at the meeting almost immediately after. And their perspective was that what might you actually see change in TEFCA based on this? Is that TEFCA had kind of fallen back with some changes made the end of last year, more to a veto mode where it would, the RCE and the QNs would operate fairly independently, and then the ASTP ONC would just kind of have veto rights. And the QNs felt that perhaps this administration was like, no, that doesn't support go fast, and that maybe they do want to exert more, they want to be able to influence TEFCA more to get that acceleration, which I thought was a very interesting potential outcome. And I think it's a big plus. I think we've got two areas that are slowing things down. One is the supposedly required mandatory individual access services use exchange purpose under TEFCA, and yet there have been some barriers that have arisen, and I'm hoping that this emphasis on individual access to patient data will help remove those barriers. If TEFCA can't enable IAS, why are we doing TEFCA? Why don't we just do carry quality? Because we're already moving all the clinical documents for provider-based exchange. Just my opinion. We got to make it happen, and I do think that is a goal. And then the second one is there is a more narrow definition of treatment. We all know and understand why that happened in TEFCA, but it also does leave some folks, today outside that TEFCA exchange, and those are people that are non-covered entities. And I think that there may be some more conversations around that, because they always intended to kind of come back to that definition and start opening it up a little bit more carefully, always balancing trust. And I think that will help accelerate. This is going to help accelerate those things.
Super. I cannot tell you all how much this means to us to have you be part of this conversation and help to guide our discussion. What is it, 3,000 miles away out of DC? So thank you for your expertise, your leadership in this work. And hopefully you can stay on and address any questions that come in from our chat. And I know that you are accessible out there. And we're happy to be able to connect and do the dot connection too. If anybody wants to make sure that you all stay connected, we're happy to do that. But I am watching our time. I'm trying to do this facilitation role, and we have a fantastic presentation that actually I think goes hand in hand with health plan and HIE working together to be able to accelerate FHIR and better connection. So I'm gonna hand it off to Olivia to be able to make the introductions, and we will hear from them.
Thank you, Timmy. And thank you, Ali and Tom, for being here today. I agree. I think this is a great extension of what we were just talking about, learning how FHIR is really working on the ground with organizations. So I'd love to hand it over to Ali Modaresi and Tom Schwaninger. Ali is the CEO of Lanes, and Tom is a senior executive advisor for digital interoperability at LA Care Health Plan. And we are excited to learn more about a new FHIR-based exchange initiative that these two have been successful in collaborating on. So with that, I'll hand it over.
Great, thank you, Olivia. I'll start with some of the sort of high-level background from the LA Care perspective, and then I'll turn it over to Ali to kind of give more detail on the actual implementation and what's happening. But let me just say, and also for full disclosure, I should say that I am the chair of the Lanes board as well. So I'm on both sides of the fence in a bit. But from an LA Care perspective, we have been partnered with Lanes even before it became operational. Lanes was initiated by the LA County Board of Supervisors, I think around 2009 or maybe even earlier. So it's always had a lot of LA County support from the various health operations across the county, and it really started with the county pushing the idea, and they didn't even call it an HIE then. It was just a way to share data so that residents of LA County could have healthier outcomes. LA Care has always been an integral part of LA County, and so we've supported Lanes from the early stages with some financial commitments, and we were among the first participants in Lanes, which I think was about 10 years ago. The county health system began sharing data with Lanes. LA Care began sharing data with Lanes and some of the FQHCs as well in LA County. So we had a good start with a good critical mass of data flowing into Lanes. And from there, under Ali's leadership, thank you very much, Ali, the organization has grown and has really become very robust in terms of its participants. And also, I will say, as I'm fundamentally a technologist, Lanes has implemented really robust, latest and greatest technology that's FHIR enabled, based on using the latest standards and things of that sort. So from LA Care's perspective, we view Lanes as our hub, the hub for LA Care for data exchange across LA County. We have participation with some other vendors and players to fill in some of the gaps, but at the end of the day, our strategic vision is that Lanes is the hub and the source of data for LA Care, as well as for LA Care's contracted providers and network across LA County, and even now some of the edges of LA County as we've gone and addressed some needs outside of the county itself. We as a health plan didn't know really how to spell HL7 or FHIR, but we found out when the CMS rule 9115 came out around, what was that, 2021, something like that, in the midst of the pandemic. We were like, oh, what is this stuff that we're supposed to do? So it started with plans having to do patient access APIs using FHIR, using the implementation guides that were out there. And so we said, okay, we're going to commit to FHIR. We're going to make that our primary transport vehicle standard for data exchange. Around the same time, Lanes converted to their Google FHIR platform. And so we have taken the opportunity to do FHIR exchange as much as possible with other organizations, and obviously Lanes being the primary one. So for us, the idea of Lanes as a QHIO and as a community health resource in LA County, we view it not just as a way of satisfying some of the regulations from CMS and of course the statewide data exchange framework, which I was very skeptical anything would happen in the beginning, to be honest, and I'm really pleased to say with the help of this group and others, it's really progressed and is progressing. But we want to do more than that. We want to really share robust data about our members. We want to be able to obtain that data also that we can get better outcomes. I'll note that Lanes is a nonprofit, so their mission has to be financially sustainable, but at the same time, they can afford to do some things around the edges that may not make money, but serve the community well. So with that, I will turn it over to Ali, and he'll talk about what we've done and how we've done it, and I'll go on quiet. Ali?
Thank you, Olivia. Hello, everyone. It's a real pleasure to be here today to talk about our claims exchange project with LA Care. This project, which began over a year ago, uses FHIR technology to receive inbound claims and encounter information. This approach has several advantages over the traditional EDI X12 claim file exchange, which has been in place for over 30 years. And then we'll get to the the advantages that this approach that the FHIR has over the X12 claims. Actually, if you could go back, Maya, to the earlier, and one more, please. Yeah, because before diving into the technical details, I'd like to start with a quick introduction of Lanes for those that are not familiar with our organization and who we are and the role that we play in the community. So Lanes is a nonprofit, community-driven, qualified health information organization. We enable health data exchange, clinical data insight at point of care, and population health capabilities. We've developed tools and tool sets and apps empowering providers across the health and social service ecosystem to deliver more effective, coordinated care more efficiently. Next slide, please. Our network has grown significantly in the recent years and now includes over 13 million unique patients in our clinical data repository. Our participants include hospitals, health plans, FQHCs, mental health, behavioral health organizations. Some of these organizations operate across statewide. Other key stakeholders are IPAs that play a key role in care coordination. And now we've added several social service organizations and we are kind of working towards the having social determinants of data included as part of the clinical data. Next slide, please. So this engagement with LA Care consisted of two distinct projects. The first is real-time ADT encounter notifications from Lanes to LA Care, and the second is inbound claims and encounter data and explanation of benefit information from LA Care to Lanes. Both of these are driven by important regulations, CMS interoperability that Tom mentioned, as well as the DXF. Next slide, please. So to support this project, we deployed a robust fire exchange infrastructure on both sides. On LA Care side, vendor is Edifax, the fire server release 4, and Lanes, Google Cloud, Healthcare API, same release 4. We also deployed Lanes interface engine, which is Mirth Connect on AWS. We use Verato Master Patient Index for patient matching, and for security, we use the Auth 2.0 authentication protocol to establish secure connection between the two servers. Next slide, please. The first project is a real-time ADT notification. It started with establishing a secure fire connection between Lanes and Edifax. We translate inbound HL7 V2 ADT data from hospitals into the fire bundles, which then include the fire resources that we used for this project was encounter, patient coverage, organization, location, and provider fire resources. That fire is because of these resources that they have, it makes the exchange much more efficient, fast, and quick. Obviously, Edifax had some different variation of the implementation, so we had to actually adapt to this to the bundles to meet their specific requirements. But in talking with our technical people, they think that the level of mapping is much less intrusive than using the HL7. Although in this case, this was our first larger scale implementation, it took several attempts in getting it right, and so that ADT fire-based ADT notification is now in production and into the LA Care. I believe they call it ADT Data Mart or some data lake. Next slide, please. So the meat here is this the second project was receiving claims and encounter data from LA Care. This is started by establishing a secure fire connection for both bulk and incremental transport. The data from Edifax is mapped to our minimum data requirements. It's validated and then stored for ingestion into the fire repository. We are looking at the use cases for this, leveraging this data. And one of the first use cases that we are working on is the gaps in care reporting. So what's the advantage of this using FHIR over the EDI X12, the 837 format that has been in place for many years and it's been working great actually, but now there's this better technology or faster technology that has advantages because of some of the things that I'm going to mention here is that first, obviously, it aligns with CMS interoperability. And more importantly, this FHIR kind of a resource-based modular design integrates the clinical data and administrative data seamlessly. And this is great for us as a data aggregator. We would be able to pull this clinical data out of this FHIR resources and integrate it into the clinical data in clinical repository, which kind of covers the gaps in some of the with the organizations that we do not have direct connections, but through the claims file, we will be able to get some of the clinical information. While the X12 format or the technology is effective for financial and administrative purposes, FHIR keeps this patient records and the data sets is all together, so it's easier to ingest. And for us also, it was easier to compare what we receive from the claims and compare with what we actually have in the clinical data repository, because we don't want to kind of duplicate the effort, but we want to fill the gaps in the data that we've collected directly from the EHR systems. So it kind of makes it a kind of the information the transport of this information is smarter, faster, and kind of more coordinated. And the mapping exercise is during the implementation is less time consuming. So the claim files, the clinical data that the providers that we are not connected to it, we are now looking at those data in ingesting it into our data repository to be able to develop a more comprehensive gaps in care documents. Next slide. So some of the challenges was variation in Edifax FHIR implementation that requires some custom mapping. The multiple patient identifiers from LA Care, because they have multiple line of business, and so that kind of reconciliation of patient matching was a little bit of a challenge. And then also the bulk transmission or submission, and there is a timeout that we are working with Edifax to fix that issue. We've kind of it's a problem on their end, on their server, but those are the issues that we've been working with throughout the implementation. Next slide, please. So lessons learned, early alignment on FHIR specification is a standard. So just like any standard we use, it's typically 90% the standard, and every organization has their own variations. So early alignment is helpful. Validation and mapping requires significant time and resources. And we went back and forth this project to several months and weeks to get through each phase of the project. Change control and versioning are critical for mapping and keeping the profiles. Automated testing and robust validation workflows improve the quality as just with any other implementation. Performance monitoring is critical for this bulk fire exchange. This is our first one that we are doing, and we are kind of learning through this process. And then regulatory projects have benefits from clear compliance roadmap. So we are running into situations where, it's an interpretation of the regulations. For example, we are expected to receive historical claims, and that's not our interpretation of the regulation, but I think we are working to better understand. Typically, when we onboard an organization and do the integration, this just we move forward. We don't go back and collect historical data. So we are trying to clarify that aspect as well. Next slide, please. So next steps for us is to develop care gaps reporting for the ECM population, that we have a large number of ECM providers and patients in our system. And by receiving these claim files, we are able to get clinical data that from providers that are not directly connected with us, and produce a meaningful gaps in care type of reporting. We will continue our privacy officers in making sure that we continue in compliance with CMS and DXF, and then offer and expand claims and encounter ingestion to other health plans that they would like for us to work with them. With that, I'll turn it back to Olivia, and happy to take any questions.
I'm gonna jump in, Olivia, if I can. We're just so thrilled to see this. I know we've been asking for this presentation for a while, and we saw the press release go out, and I think it's a huge milestone that we all need to recognize, and thank you for leading the way there. And then also, we'd love to be able to, I would think you have health plans lined up for this, to be able to start expanding. And to Paul's note in the chat, where and how can we get an evaluation that shows how much savings this is going to produce from the old way to the new way? Because it just seems like we're kind of really breaking through here. And if you want to be able to share that, share some comments there, just an observation that I had.
Or if you have any comments before I...
No, I kind of put it in the chat. I mean, I think, so often we've been, working for years on interop, and it's been all about clinical. Meanwhile, all the claims and eligibility and prior auth and everything else was over there, and those two worlds never came up. And that's literally why we send 9 billion faxes in American healthcare. So this is, I mean, we've been engaged with, conversations with folks at the state who are desperately trying to figure out how to save money. Let's actually, step up and say, interop is not just a good thing and nice to have, important for clinical, but actually can make our system much more effective, because budget cuts are coming, and they're going to be brutal, because that's the reality. And we've got this tool, in every other industry, digital tools actually create more efficient operations. So I just think this is a crisis moment in California and every other state, frankly. This is a red state, blue state, everybody. And but again, and I think this is a huge foundation that you guys have just laid out. I think we take a step further and also talk about prior auth, talk about claims, talk about eligibility, the actual, not just retrospective claims, but the actual real-time administrative transactions. And again, why are claims such a pain? Why is prior auth such a pain? Because old X12 transactions don't connect to clinical data. And that's why, exactly, make faxing great again. That is why we send 9 billion faxes. Hey, doc, we'd love to approve your claim. Please fax us clinical notes times 9 billion times a year. It's insane. But when we
Paul,
this clinical, interop
100%.
world,
Yeah, no, I just want to, I'm again, just watching the time, the facilitator hat. I cannot agree with you more. And that is why we were so excited to have this presented to us. And if there's a way to be able to show that the state is putting the gas, the gas to the pedal to the metal, this is it. So we really want to stay close. Please, Lanes, LA Care, think about where and how you're seeing savings, thinking about where you're applying this into use cases that are making real change happen. We're very eager to see it. And I'm sure many of us have ideas on how we can really take this and scale it. So I'm gonna move us to our next section, which is we have lots of really additional, I think we can, I know we took a break, that we were not together 2 weeks ago, but that's what happens. We have so much to pack into this first meeting. So Ben, you want to take this over with making sure everybody saw this other announcement from the White House?
Yes, definitely. I think it leans really well, or segues well from the conversation we were just having. So I'll keep it really brief, but going to do a quick overview of the Rural Health Transformation Fund. So this was one of the pieces of the really large bill I think most are familiar with as the Budget Reconciliation Bill, officially the One Big Beautiful Bill Act, signed on July 4th into law. So I think, top of mind for most folks is the $1 trillion in cuts to Medicaid that the bill included over 10 years that the Congressional Budget Office estimated would result in 10 million folks becoming uninsured over the 10-year period. During conversation about the bill, there was a lot of concern, of course, from members of Congress representing rural states, rural areas. And so in response to that, they created this program within the bill for $50 billion in grants called the Rural Health Transformation Fund. So the fund is appropriated evenly across 5 years, so $10 billion a year from FY 26 to 30. And then as you'll see in a second, as I get into it, we're talking about this today because this is one of the first things that's going to happen from the reconciliation bill in the healthcare space. States are going to have to apply to CMS to access these funds. And CMS has said that application's coming out early next month in September. And they have a deadline in law to approve or deny all states by the end of the year. So you would expect a lot of this to move pretty quickly. So, could you go to the next slide, Maya? Yes, just an overview, kind of visually outlining what I was saying. Those applications are going to come out in early September. I would note that a few states are already starting to put out requests for information, surveys to stakeholders about what those applications should look like. So we're already in this stage even before September of states seeking that input. And then I was mentioning CMS has to either thumbs up or thumbs down those applications by the end of the year, meaning that the application you can expect to close not too long after early September, and those decisions to come out from CMS before the end of the year. And then I was saying you'll have program funding evenly distributed across the 5 years from FY 26 to 30. And then states have to obligate or expend those funds by October of 2032. Next slide, Maya. Cool. And then just to get into some of what those applications have to look like, how CMS will make those allocation decisions, and then what can those funds actually be used for. I think a common theme you'll note across these three that I want to highlight is that CMS and the administrator have a lot of leeway and latitude to make some of these decisions within some parameters set by the law, but then of course CMS has a lot of ways to decide how they're going to make those decisions. So again, states will apply to CMS. CMS has a lot of latitude to approve or deny those state applications. When it comes to the allocations, the law does say that the funds have to be divided into two pots equally. So 25 billion has to be distributed evenly to all states with approved applications. The other 25 billion is going to be distributed according to some formula that's devised by CMS. The law lays out a bunch of parameters that CMS will have to take into account that include a lot of different measures of what a state's rural health needs are, like the rural population, how many rural providers the state has, and what's the state of those providers. But then again, going back to my theme, CMS has a lot of discretion in what are the different, how those different factors are going to be weighted, and then also to add in factors it decides are important too. So that allocation to states could vary quite a bit. But given all that uncertainty, we've done some, I'd say, back of the envelope math that, in the case that California's application is approved, you could expect somewhere between 500 million to 1.5 billion to the state over those 5 years. And then just last caveat here, states can hold up to 10% of those funds for administration. So then lastly, if we take a look at this box on the right, this is what is written into the law of what states can use the funds for. They actually have to use it for 3 or more. And this list is not completely comprehensive of what's in the law, but some of the biggest buckets of uses that can be used. And then I just draw your attention again to the last bullet. Again, CMS can add other uses to this as they deem fit. But I think this will be the basis for what states will want to base their applications on, and saying that they're going to be touching at least 3 and probably more of these buckets of funds, uses of funds. Next slide, Maya. Thank you. So lastly, just quick considerations, what this means for California for C4BH. If I haven't already made it clear, timing, I think, is the big one, with the CMS applications coming out in early September. And then I was mentioning, a lot of states are already starting to put out those RFIs, those surveys to stakeholders. So expect California not to be far behind. And then, as it comes to data exchange, a lot of things we've been talking about, it fits very well within a lot of the uses the law talks about. So funds could support things like capacity building to meet the requirements of the DXF, including technology, TA, staffing, and also support systems for social services data sharing and care coordination. And then I'll wrap with the last point, is just that you'll hear a lot of the discussion around this fund as it was being developed, and then now around rural hospitals specifically, as some of the folks facing the biggest challenges with Medicaid. But the law itself is written agnostically, so the funds can be used to support a wide range of providers across the continuum in rural areas and serving rural patients. So hospitals, clinics, other health providers, all are within the realm of what the law speaks about. So I know it's very quick on the fund, but available for any questions y'all have, and we'll turn it back to you.
Great opportunity for us to keep our eyes on whenever we see funds that are coming our way that have IT and interoperability as part of the framework, or as part of the discussion, where we get really excited. So I think it's great for all of us to know that this is something for us to watch, for us to be able to talk to our state colleagues, of understanding how this will be shaped, how they're going to be collecting input. And of course, we're standing ready to be able to provide that input as well. Stephanie, I know we just got a couple more things that we can run through.
Yeah. Olivia, you want to take it away?
And thanks, Beth.
Yeah. Oh, sounds good. There's been a lot of federal news, a lot of state news, and unfortunately we did not have time today to dive into all of it, but we posted the highlights in our slides. So some quick federal updates. The White House put out an AI action plan while we were on break. ACP has finalized HTI 4. We also linked to a great Politico article that references some recent quotes from Dr. Tom Keene of the Assistant Secretary for Technology Policy. And then our next slide has a few California-focused updates. If you guys missed it, C4BH is officially launching our health and homelessness community practice that went live on August 1st, and we're in the process of recruiting COCs and MCPs and their partners and regions to come participate. So stay on the lookout for an application to get involved. DHCS also released their updated Ask Me form that's available on their website. And I just want to make sure it's on everyone's radar. There are 2 public comment opportunities right now. One around administrative modifications to the DXF policies and procedures, really focused on supporting the transition of the DXF from CDII to HCI. And then also DHCS put out a CalAIM Medi-Cal concept paper speaking about their intentions for the waiver moving forward as it's set to expire. So links to everything is in that here. And then I know we're at time, but Maya, if you could just fast forward me on, would love to make sure that people are aware that our save the date for the annual 2026 annual dinner is now out there. So we hope that people can mark it off on their calendars to come join us on March 4th. In Sacramento, we'll be at the same location at the library, which was beautiful last year. And then please reach out if you'd be interested in learning more about sponsoring. And I think that is it for today. Thank you all for staying on. We just made it at time, and slides will be on the website so folks can go back and do a deeper read of everything.
Hey, Olivia.
Yes, hey.
Hi. Timmy just mentioned something about a panel. What's this CHCF panel before anybody leaves?
Yeah, so it's actually about to start right now. CHCF is hosting a data policy briefing focused around California that is taking place in Sacramento.
Is there a link to it? Is it virtual or is it all in person?
It's only in person, but I can put the link in the chat. Maybe you might get to it before me.
Thank you.
They have a good lineup. I know that HCI will be there today. Here we go. I've just found the link.
Awesome. Thank you so much.
Of course. Yeah, Elizabeth Lansberg will be there, Sandra Hernandez, also Julia McConaughey with Prospect Medical Holdings. And then
I
also,
would have loved. Yeah, I would have gone up to that.
I swear it was in
seems
our newsletter.
No,
But
I have
we'll
no
make sure
doubt.
that we keep getting these events out to everyone.
No, that's right. There's so much happening. It's hard to keep it all straight.
I know. What happened to a slow summer? I feel like everyone's been pushing forward.
Cool. Well, I really appreciate that.
Thank you all.
Awesome.
And I'm sure we'll do a report out on it when we come back in 2 weeks.
Is it just kind of an update, or are they talking about policy? What's their spiel today?
I think more focusing on how healthcare or how data exchange can support quality, control costs, expand access. I think high level, and also getting into detail on next steps for what California can do.
Okay, it's more like a thought exercise type of discussion, or like they meeting with people to try to make decisions about policy.
No. I would say it's more of a thought exercise.
Okay, awesome.
But it's open to the public.
Yeah, that's
Open for everyone to be there. All right, everyone. Thanks for staying on for a few extra minutes.
See ya.
Have a great day.
Thanks.